Want to go ahead and click record, then we will kick off the webinar.
All right, we're live.
Great. Hello, everyone, and thank you for joining the National Telehealth Webinar Series. My name is Danielle Louder, and the Program Director for the Northeast Telehealth Resource Center, or NTRC, as we like to say, serving all of New England, New York, and the northern part of New Jersey. On behalf of all 14 telehealth resource centers across the country, welcome to today's webinar. Along with our colleagues from the Center for Connected Health Policy, the NTRC is excited to host this month's session, which dives into eConsultations, or better known as eConsults, which use telehealth technology to enable enhanced communication and information exchange between providers, and are really emerging as a solid tool in addressing barriers to access and timeliness of care. And we certainly have a couple of expert speakers who are going to share their different perspectives with us today. We're very excited about that. Before I introduce today's presenters, I want to share a brief overview of the telehealth resource centers for those who are less familiar with us. This map shows our presence across the nation. There are 12 regional telehealth resource centers, which collectively cover all 50 states and the Pacific Basin. If you've not had the opportunity yet to connect with your regional TRC, please take a moment to find them on the map. And we really hope you'll reach out to see how you might work with us moving forward to advance your telehealth efforts. There are also 2 national telehealth resource centers. Our colleagues at the Center for Connected Health Policy out of Sacramento, California, focus on the ever-evolving landscape of policy, telehealth policy. And our friends at the Telehealth Technology Assessment Center at TTAC out of Anchorage, Alaska, provide impartial assessment and feedback on the growing spectrum of telehealth technology. The Telehealth Resource Centers are funded through the U.S. Department of Health and Human Services Health Resources and Services Administration's Office for the Advancement of Telehealth, which falls under the Office of Rural Health Policy. The TRCs have been in existence for more than 10 years now and were established to provide assistance, education, and information to organizations and individuals actively providing or interested in providing medical care at a distance. Our mission is to expand availability of healthcare to underserved populations through telehealth. And because we are federally funded, the assistance we provide is impartial and generally free of charge. Just a couple of tips and tricks or notes for the webinar today. You will notice that both your phone and or your computer microphone has been muted for you, so no worries there. If you need to use your keyboard to take notes, or if you need to grab a quick crunchy snack like I often do, you're all good. If you have questions for our speakers, please use the Q&A feature at the bottom middle of the screen. Just type in your question and we'll do our best to answer those questions at the end of the session. If we don't get to them, we will certainly follow up with more rigorous feedback, resources, etc. And if there are more general questions during the session, we'll try to get those answered via the chat, so keep an eye on that. If you have any technical difficulties today, please call 317-517-3961. And so now, without further ado, we will jump into our webinar. We want to give our speakers plenty of time to share their expertise and perspectives. So the title of our webinar today is Moving Knowledge, Not Patients, Rethinking the Way Primary Care and Specialists Work Together for Improved Quality, Value, and Patient Experience. Love that title. Many thanks to one of our first expert speaker for sharing that title. He has done this presentation in many different areas due to the increasing interest in eConsultations, and was actually a panel speaker at our recent NETRC regional conference at UMass Amherst at the end of May. Dr. Darren Anderson is trained as a general internist in primary care and has worked in safety net practices his entire career. He currently serves as a VP and Chief Quality Officer of Community Health Center, Inc., a large multi-state community health center providing primary care to over 140,000 medically underserved patients across Connecticut. In this role, he's responsible for directing all quality improvement work across the agency. Under his direction, CHCI has developed a highly effective QI infrastructure focused on engagement of frontline staff, coaching, and data-driven improvement. Dr. Anderson is also the director of CHCI's Weitzman Institute, a research and innovation center dedicated to improving primary care for underserved populations. The Weitzman Institute provides technical assistance and training in telehealth and quality improvement to health centers across the country. Weitzman's Project Echo and eConsult platforms are among the largest and most innovative in the country and now provide access to care for hundreds of providers in 25 states. In addition, Weitzman researchers are engaged in a range of research projects focused on primary care for the underserved. Dr. Anderson is the principal investigator for several of these projects focused on health disparities, healthcare access, and pain management in primary care. Our second speaker will be Libby Segarra. She brings 15 years of experience in program management, technical writing, and facilitation to her role as health IT and management consultant at Blue Path Health. Her previous work includes management, business development, and communications planning experience in technology and healthcare, and is skilled in managing clients, teams, technology partners, and program funders. Prior to joining Blue Path Health, Ms. Segarra was a senior associate at Booz Allen Hamilton, where she managed projects in health information change, strategic and operational planning, life sciences process improvement, and not-for-profit business and transition planning. Before Booz Allen, Ms. Segarra worked at Manat Health Solutions, the policy and business advisory division of Manat, Phelps & Phillips LLP, where she'd led health information exchange planning and readiness for state and provider organizations. So without any further ado, I think we will go ahead and turn it over to Darren. And Darren, you should have control of the slides.
Great. Danielle, thank you. Thank you so much. And thanks for the opportunity to present to our national audience today. I'm excited because I'm going to tell a story. And I love stories. I'm going to tell a story really about how frontline primary care providers can have good ideas that can inform research, that can lead to improvement in our patients' lives and ultimately even to change in policy. And the frustration is really, I think, demonstrated in this email. This is a real email that I copied off of Microsoft Outlook sent to a provider by somebody that we call at our health center a referral coordinator. And many of you probably have a similar position. I like to describe them as having the unenviable job of having to find specialty referrals for patients that nobody wants to see. And that's a sad reality in our environment, in care of the underserved for a wide variety of reasons. Patients without insurance or patients with Medicaid tend to get the short end of the stick when it comes to specialty access, and throw in being in a rural location, and it can be even worse. But if you can see from this email without reading it, doctors, and this is in Connecticut, which if you look on a map is not particularly rural. You wouldn't think would be so underserved we have 13 hospital systems that we interact with in the state of Connecticut. Despite that, Dr. X of Yale Orthopedics noted that all orthopedic referrals from the shoreline of Connecticut were to be scheduled locally. If there were no local orthopedics, then they are to be referred to UConn, which basically means in this shoreline community, a relatively poor community where the consult was coming from, they didn't want to see patients from that area and wouldn't take them, and instead we had to send them an hour and a half away to UConn, which is way up in the northern part of the state. And a similar story about local dermatologists now declining to accept Medicaid referrals from specific towns and cities where we were practicing. And so, as the email ends, for this means for me, this means I have nowhere to send my managed healthcare patients when they need an orthopedic. And for dermatology, there's nowhere to go. And I love the last line. It stayed with me ever since. This was in 2012. Can my job get any harder? Question mark, question mark, question mark. Well, I think the answer and the whole point of this story is your job can get easier because primary care providers around the country have come together to figure out something sensible and figure out a way to address this problem and make it better. And that's the story that I want to tell you today. And then, oh, there we go. So we're going to take a slight deviation to this person. So back in the Middle Ages, if you were seeking knowledge, if you were looking for the answer to a question and you wanted to look something up, the only place where really the sum total of human knowledge resided, at least in Europe, was in cloisters, in churches. And if you wanted to know what the Bible told you or how you should live your life or find out what the Greeks thought about the Pythagorean theorem, really all of that information resided in cloisters, monasteries, and churches until this person came along and had a very, very seminal invention that turned everything on its head. This is Johannes Gutenberg, who invented the mobile type printing press. And soon after this invention, Bibles and books and all sorts of knowledge started being reproduced and spread around Europe and ultimately around the world. And what that meant was that people outside of academia, people outside of the church could now access knowledge for themselves. And this ushered in the Age of Enlightenment. And not to push the analogy too far, but in our view as primary care providers, when we need an additional piece of knowledge, when we have a question and we don't know the answer to, we often have to go to the cloister or the academic medical center or the specialty center to get an answer to that. And I would put forth to you that the invention of this new approach, the eConsult, has turned that on its head and has given us a new way of exchanging knowledge and sharing it in a way that is much more efficient and makes a lot more sense than the process of taking a patient and referring them, waiting several months, faxing the information over, hoping that they get to the appointment, hoping that the specialist speaks their language, and that hoping that we will get a referral note back from the specialist telling us and advising us what it is we should do. Danielle, I'm having, oh, there we go. So this is the Gutenberg Bible, and this is an eConsult. So this is an example of, if you remember that email that was sent by that frustrated referral coordinator, this is how that same consult, actually from the same provider in the same community, is now done. These pictures are obviously of a baby with 2 different types of rashes. And at the time this was done, there was a 9-month wait. There was a 9-month wait for a referral to dermatology. Oops. This is the recommendation that came back several hours later. And you can see it comes with a detailed diagnosis and a detailed treatment plan, which doesn't just say things like, it could be this, it could be that. It really says, this is what it is, and here's what you need to do. And the provider in question who treated this baby was able to call in this recommendation to the pharmacy, and I reached out several months later and found out that the baby got better within a couple of weeks, and everything was resolved. And this is now how that same orthopedic consult was done now in 2016. And you can see, I won't read through this consult, but this is a 32-year-old patient with an ACL tear that was over 4 years old, and he, as the provider put it, was perseverating on getting an MRI, was deeply concerned about the need for a surgical consult and reluctant to re-engage with physical therapy until after an orthopedic consult. And the orthopedist walks through the clinical documentation from the primary care provider and says, this candidate may not be suitable for surgical reconstruction because the ACL is over 4 years. The tear is over 4 years old. It's too late, and instead, there's also no need for an MRI. The quad and hamstring rehabilitation is the key for improving knee function. And I'd like to show this example, 1, because it provided reassurance to the provider, 2, because it educated the primary care provider about how to handle cases that they see in the future, and 3, because insurance companies love to see this one, because you can see that an MRI and a visit to orthopedics was prevented with one simple electronic exchange of information. So we decided to test this whole concept out in a more rigorous manner. Certainly the eConsult was pioneered out in California at San Francisco General Hospital, and later in LA County, and has now been really operationalized at scale. But much of what they've reported is really observational data, very impressive observational data. But we thought that, at least on the East Coast, where people aren't quite as innovative all the time, that we needed the language of academia, and we needed the currency of academia in a randomized controlled trial. So we actually randomized all of our primary care providers in Connecticut at Community Health Center, and half of them, those that randomized to the intervention, got access to eConsults for cardiology, and the other half didn't. And then we watched to see what happened for all of their consults in cardiology over the course of a year, and followed every consult for 6 months afterwards to see what happened to the patient. And I won't go into the details of the study design. It was a very robust study design. We used an intention to treat analysis, and we're able to show that in the eConsult arm, 69% of the consults sent to cardiology did not need a face-to-face visit, and were completely resolved to the satisfaction of the provider with an eConsult alone, and 31% required a face-to-face. In addition, what we highlighted here was there were no negative outcomes in either group. We were in no difference between the intervention and the control patients. Nobody died, nobody had an MI. But what was statistically significant was the group that got the eConsult was was less likely by half to need to go to the emergency room or to have an emergency room visit for potential cardiac symptoms. And when we got claims data from Medicaid and were able to look at the impact on total cost of care, you can see on this, these are cost curves for the intervention and the control. The intervention group with eConsults is the solid line, and the face-to-face group that didn't have access to eConsults is the dotted line. And what this shows is a $500 per patient savings on average, $480 on average per patient in under 6 months. That largely resulted from lower numbers of cardiac tests and procedures and ER visits and the like. And so we felt that combining what we knew from LA County, from San Francisco General, from other eConsult programs that have been emerging in Canada, and our own experience, that we had really hit the quadruple aim. We have an intervention that improved patient outcomes, reduced things like ER visits, improved efficiency of the system by, with a significant percentage of cases, preventing the need to wait months and do all of the rigmarole around sending people to face-to-face visits, also satisfied our clinicians who got answers to their questions quickly that they could apply in primary care, and was convenient and acceptable to patients in making their lives more efficient as well. So, based on those findings, we created an entity called Community eConsult Network, which is a nonprofit that has a mission of spreading eConsult, spreading the word about eConsult, and making eConsult available to providers really in any location where they face similar difficulties to us. And we felt very likely that if here in Connecticut we were struggling to get access from the shoreline of Connecticut to dermatology, there were many places around the country that had similar problems. And whereas LA County and San Francisco General had been able to implement really a city and region-wide solution, not every practice was in a setting where that would be possible. And so we started reaching out to our friends and colleagues and connections in other health centers and saying, would you be interested in receiving eConsults from our network of specialists in a similar manner? And it started local. We started by implementing this in Connecticut for all of our practices across the state. And then it didn't seem too much of a stretch to add them to the state of Rhode Island. And we have a partner health center in Rhode Island just across the border that now does eConsults with us. And then Maine didn't seem too far away. And we started doing eConsults with a large health center in the Bangor region of Maine. And after that, I think we really felt we had proved that our motto should be making geography irrelevant. If you have an interested specialist who likes doing this kind of work and is a good teacher and is willing to log on to our web-based platform, and you have a needy primary care practice that has trouble with access and wants to expand its scope of primary care, we can link them electronically using a variety of different technologies and let the consults flow. And that's exactly what we did. And at present, we're now offering eConsults to practices around the country in a wide range of specialties, just like the ones that you see here. And as recently as this week, we added transgender care and ENT, so those have to bump up from coming soon to the current network offerings. And we find each one of these specialties has a different sort of story behind it. And I spend a lot of my time reading and reviewing the consults and seeing what they're like. And whereas many orthopedic and GI consults require procedures, colonoscopies, orthopedic interventions and such, even those, there are many that don't and that can be reviewed and discussed electronically and make the system more efficient. Whereas specialties like rheumatology and nephrology, much more significant percentages of those consults can be managed completely electronically without patients needing to travel. So this is kind of, the bottom line, punchline for how we have, for what the impact has been now on a large practice statewide over about a year's time. We have 54,000 Medicaid members who had access to eConsults over the past year, and you can see the punchline is kind of in the bottom right-hand corner that 21% of our total face-to-face volume was there was a 21% reduction in the total number of face-to-face consults that we sent over the course of a year as a result of eConsults. And just to kind of walk across the columns, the first column shows the total number of adult medical referrals that we did for the specialties that I've listed, 11,000. And a percentage of those, 3,000 some odd, were appropriate for eConsults. And so what we did was, with using a clinical protocol, we weeded out colonoscopy referrals, post-surgical follow-ups, things that really needed a face-to-face and didn't qualify. But then if you continue over, you can see the vast majority of those 3,000, 75% in total, were resolved electronically. And so we think that where this sort of a model fits in, it's a critical tool for not only addressing issues of access, but for improving efficiency and improving clinical outcomes and saving money as well. And so practices that are part of ACOs, practices that have value-based reimbursement payment models, practices that are at risk or have shared savings would do well to implement a process like this, because if you can reduce face-to-face visits by 21%, that has an immediate positive impact in a wide range of areas, not to mention your bottom line. And so as we continue to collect more data from our partners, these numbers have held up. This is not just, we see similar numbers with our implementation in Maine and Washington State and in other locations as well. And so I think just to make a slight transition to Project Echo, I think probably many of you are familiar. We have layered on eConsults with Project Echo. For those of you not familiar, Project Echo is a video conference where specialists and primary care providers come together and discuss challenging topics like Hep C management or HIV care. We have a national Project Echo that trains providers in how to manage chronic pain in a multimodal way. And I think the way we see eConsults and Echo fitting together, Echo is a wonderful platform for discussing challenging topics that really need more than a simple transmission of electronic data through an eConsult. But layering in eConsults to be able to discuss those cases with that faculty and implement their ideas and exchange things electronically adds value to Echo, and Echo adds value to eConsults in that it gives you a forum to discuss some of those more challenging topics as you need to. And so we've actually kind of layered these two on together as part of our overall telehealth strategy, both of them scalable, up as high as a national level. And these are some of the topics that we offer for Project Echo. HIV and Hep C. We've just completed a national LGBT Echo that was training providers that wanted to develop additional competency in caring for LGBT people. Pediatric and adolescent behavioral health, buprenorphine, chronic pain. These are some of the topics that we've identified that really primary care providers need to gain competency in how to manage these things. And we felt that adding an Echo with eConsults layered in has proven to be a really effective way of doing that. And so I think to end with a picture of a map, one of the things at the Weitzman Institute that we've been really focused on is scale. It's really difficult to envision setting these types of networks and systems up, town by town and hospital by hospital. And I think that may not be necessary. We've been able to take eConsults and scale it across the nation and add in Project Echo. And you can see every state where there's a dot, a blue dot or a green dot, are places where we have health centers that are working with one of these projects, Project Echo or eConsult or both. And we've been able to take it to a level of scale. I think that really demonstrates the potential of a model like this to address on a national level issues of access, specialty care, and primary care scope of practice. And so with that, I will end and pass the virtual baton over to our next speaker.
Okay, great. Thank you so much, Darren. That was fantastic. And we do actually have a few questions that are very specific to CHC's model, and I think they look pretty quick for you to answer. So if folks don't mind, I think we'll go ahead and have you answer those quickly. If something sounds like it's going to get into too much detail, then we can kind of skip through and go to the end because we really want to make sure that Libby has enough time. But just a couple of questions. What are the licensure requirements for eConsults?
Yeah, that's a really good question. And we have a team of people, many of them lawyers, who have spent a lot of time helping us to answer this question. And I think the long answer, which I won't go into, is that every state is different. But the short answer is states tend to fall into two different categories. The first is a state where the licensure laws specifically state something similar to what I'll describe here. They will say, consultations between providers, whether electronic or otherwise, do not constitute the practice of medicine or the establishment of a physician-patient relationship, and as such, do not require a license in our state. And there's other states that have a clause that basically says the exact opposite. Consultations between clinicians in any form, whether electronic or otherwise, do constitute the provision of medical care and as such do require in-state licensure. The good news is that many of the most progressive and largest states fall in the former group. States like Washington, Oregon, California do not require in-state licensure for for consults like eConsults, as I've described. And this is a rapidly changing landscape, so we have to really keep on top of them and keep track of legislation as it moves forward in this area.
Great, thank you. So another question, how did you get buy-in from specialists to handle eConsults, or i.e. carving out the time? Did they get RVU, reimbursement, et cetera, for these consults and time spent?
Yep, that's another great question. So there's two answers. In the simple answer is we pay them. And there are some clinicians who embrace this as an opportunity to earn revenue with no overhead. And I always like to kind of joke and say your specialists can do this from their boat or from the beach or from their home or wherever they want to do it. Since most of the eConsults don't take an awful lot of time, you can do a fair number of them over time. So we have many clinicians specialists in that category. And I think the second category are, and the more common one for our network, which is largely academic practices, many academic entities see this as an important tool to promote their national reputation, to take part in innovation, and to train and to train to new models of care. And in those cases, most of our academic clinicians, specialists are getting RVUs and or academic enhancement. They call them academic enhancement funds at UConn. And so they get recognized and they get value in other ways. And I think both of those, I would say probably 50-50 in terms of our specialty network, which is growing rapidly.
Mm-hmm. Great. So this is a related question. Who pays for the eConsults? Are these payments difficult to negotiate?
Yeah, well, and that's also a rapidly changing, the answer is rapidly evolving. Increasingly, insurance companies are paying for eConsults. Increasingly, we find Medicaid programs, like in the state of Connecticut, Connecticut Medicaid for the past 2 years has reimbursed for eConsults because they believed those cost curves that I showed you are fairly compelling. And increasingly, insurance companies are stepping forward with willingness to reimburse on a per consult basis. But I think the future of eConsult reimbursement is actually not as a fee-for-service reimbursement stream, but rather as a core element of any health system that has risk, capitation, and or shared savings and value. So actually our largest contracts are with entities that do have either risk-based contracts and or capitation, and see this as a way of improving their overall cost profile and saving money. So we either get paid by the health center or the health system, or by the insurance company is the kind of the summary short answer.
Great. So what do you mean by e-primary care practice? Could you describe what are the attributes of such a PC practice?
Yeah, I mean, I think an electronically enhanced primary care practice is one where the primary care provider and the practitioners have access using a variety of tools to specialists in a way that doesn't require fax and doesn't require picking up the phone and calling your friend. So I think the e-enabled clinician is somebody who sees patients, who submits eConsults when they need them, learns from their specialists, by the consult information they get, joins Project Echo, gain additional competence in complicated areas like that, but also obviously has access to face-to-face visits when necessary. Notice I have, I think, intentionally not included any discussion of traditional telehealth face-to-face video, which at least in our experience hasn't been much of the solution, since they're expensive, difficult to set up, hard to coordinate, and they don't do anything to address the access issue. So I would describe it more as the types of tools that I've been speaking about. And psychiatry, I see the last question. Psychiatry is not listed, and that's a mistake. We actually are doing med management psychiatry eConsults as well, and we started it very recently before I submitted these slides to this presentation. And I have to say, it's one of our most rapidly growing and I think most successful eConsult offerings is on med management for psychiatry. I think we often underestimate the amount of behavioral health care that we primary care providers provide, for which we don't need cognitive behavioral therapy and extensive engagement with behavioral health. We need advice about meds, and eConsults are very effective at providing that type of support and advice. And I'm a big proponent of using psychiatry and med management as an eConsult.
Fantastic. Well, thank you for those excellent questions, and thank you for those answers, which are very helpful. And I think we are ready to move forward. And thank you so much, Libby. You are on.
Thanks, Danielle, and thanks, Darren, for covering all the hard questions, since I think a lot of them are touched upon in our presentation here. And one of the reasons is I have to thank Darren. Your organization has been a great source of advice to ours as we sort of try to break ground out in California in terms of engaging state Medicaid and managed care plans to support electronic consult. As you saw Darren's interesting presentation, a lot of these programs out here in California are these grassroots efforts, and we're still trying to gain the support like other states have been able to gain, such as in Connecticut. So I'm going to talk a little bit more about the challenges in terms of policy and reimbursement and what we're tackling out here in California, but as part of a nationwide work group. So I'm representing Center for Connected Health Policy today. Danielle introduced CCHP earlier as part of her work. Our work group is open to all sorts of entities across the United States that are conducting eConsults. We like to engage payers, providers, consumer advocates, anyone who is trying to break ground in eConsult and get others to join and share best practices. So we'll talk a little bit about that today and some of the progress we've made and some of the challenges that still exist. See, Danielle, if I have control here. I do. Okay, great. So I mentioned we work with Center for Connected Health Policy as part of this larger effort. Our job is really to work across the continuum of the healthcare industry, looking at our state Medicaid, which you'll see here, which is referred to as DHCS, our state managed care organization, which is the DMHC, Department of Managed Health Care, our managed care plans, our DPHs, which are district and public hospitals, and our FQs. Really looking at each individual organization's challenges in supporting eConsult. One of the biggest issues, as Darren addressed, is payment, trying to figure out how to support a sustainable electronic consult program, and trying to overcome some of the challenges that Darren mentioned earlier, especially around licensure, credentialing, some of the privacy and security issues that come up. Where we really do have a broad forum of those who are experienced in these programs and just offer that opportunity to share some of these best practices. Danielle, how's the speed? Is that okay? The slides advancing okay? We hope so.
Yep.
So great. Just speaking a little bit about the advancements that have happened over the past few decades in California, you can see that it's been, it's been a tough road to hoe. You can see over the past few years we've had some interesting and exciting advancements. If you look at 2011, apologies for the fine print here, we had an advancement called AB 415, the Telemedicine Act of 1996, which we really did get some attention within our state and across the nation in terms of expanding the definition of telemedicine. You're all familiar with Store and Forward. We're still sort of stuck in these definitions, but we really do try to associate electronic consults with what is known as Store and Forward medicine, because what we see here is that we don't want to limit our reimbursement to what is now covered in California, which is telederm, teleophthalmology, and teledentistry. We see that eConsult and Store and Forward can really benefit across all specialties, obviously, and shouldn't be just limited to these three specialties. So taking this work and moving beyond just what's happening at the state, we know that this is the responsibility of all of us across the industry. So we have a great and a broad list of member organizations here. This is limited to just what we could fit on one page, and our membership grows monthly. We thank Darren and his group for their advice and their participation in our group. But what you can see here is that we have plans. We have not only private but public health plans. We have state representatives. We have small and large provider organizations, and we have consumer advocates. So we're really trying to be able to create that case to prove to our state Medicaid that this is something that benefits patients. It's not just a cost savings measure, but it's something that can improve access, both patient and provider satisfaction, which, as you all know, we have published data to support this. So we're trying to get that across and be able to share that across our state and others. So we wanted to share a little bit about what our work group has done and our findings. Also wanted to offer the opportunity, if your organization is really just getting started with the eConsult, or if you want to be able to share some best practices and lessons learned, you're encouraged to participate. We welcome other organizations to join us. Sometimes we get into some California-specific conversations around our state Medicaid challenges, but it is really helpful to hear from other states and the advancements they've made, and we do frequently share some of this terminology that we've worked on together with other states as they try to move forward with their efforts. So some of the products that we've come up with are some language that we can just share across plans, across providers, and with our state leadership to be able to talk the same language around eConsult. As you all know, it's something that's hard to grasp. I'm glad, Darren, you differentiated it from what people normally expect of telehealth. So we have live video, which many know can be cumbersome. This is something that can improve access with much less of a lift, so much less of a heavy lift, and it's hard for some providers and payers to understand. So what we wanted to do is to be able to document and share some of these key tenets that we have demonstrated and we have heard. We have many cases of improved and consistent patient and provider satisfaction. So we have a good number of pilots out here in California that are using surveys to be able to determine how patients feel about this process. And obviously, many of you have probably participated in provider surveys in terms of provider satisfaction with this means of attempting to increase access. So this has been demonstrated, and it's no longer in pilot stage. We can share this across the board in small and large organizations. What we do want to convey is this is no longer just a pilot, or it's no longer just made up of small pilots across California. As Darren mentioned, we have large university systems that are participating in these programs, large public hospitals. Out here in California, we have a program called PRIME, which is a public hospital initiative to do many things to improve specialty care access, but eConsult is a key component of that. So with our large public hospitals across the state taking this on, it's no longer just an experiment. It's a standard of care. We've proven across the board that we can improve access to specialty care and can improve network adequacy. What some of you don't think about in terms of California is that we have many varied county sizes and demographics. We have very far northern rural counties, and we have obviously urban centers. Both have specialty care access challenges, and we've seen successful programs in both types of in both types of regions. We see these consistent themes which we try to convey and share with our state Medicaid. Obviously, decreased wait times, decreased repeat appointments, and decreased no-shows, which are all published data. In terms of care coordination, we've shown across our programs that we can show that PCP capacity can be increased, as Darren mentioned with the ECHO program. We have ability to create and to strengthen health homes by connecting PCPs and specialists, not just remotely, but to be able to improve their relationships on the local level. And one thing that we do want to be able to convey and differentiate is that electronic consults are not just automating a referral process. It is really a different and perhaps more efficient means of delivering specialty care. One product that we're happy that we landed on, and it was a hot debate. It happened about a year ago with probably 50 people on a webinar. We took what was published as an American Academy of Family Physicians definition for electronic consult, and we tried to make sure that it was modernized. You know, we're looking at a definition for asynchronous telehealth that was probably documented 10 years ago. We needed to bring it up to speed, up to pace with current technology. And we're happy that we have a product that's been able to be shared across states, and then one that our state Medicaid is finally feeling comfortable with. And we're finally breaking ground in terms of getting some of that support that I'll talk about in a minute here. The other point here is that we now finally have some standard CPT codes that we can share, and that's one of the biggest challenges, as you all know, is how to be able to document electronic consult and show that it's actually occurred. And that's now between our Association of Public Hospitals and our FQHCs. They've now finally been able to come to an agreement on how to document these electronic consults. So Darren touched upon some of these programs happening across the state, and I mentioned you can see our far rural, northern, and eastern counties, you know, are larger spaces that have a huge access challenge. And you can also see some of the more concentrated areas in the Bay Area where you're seeing a lot of activity in eConsult. But these programs are spurred and they're sponsored by different types of organizations ranging from the public hospital to the FQ to large health plans. And so it doesn't mean that there's one recipe for success, but we're seeing more traction with our public hospitals because there are now more, there's more of a financial incentive for them to be able to get eConsult to work to be able to improve their referral processes. Darren mentioned there was some great work done in LA between both LA Care and LA County and really spearheading these efforts. It is a challenge, and some people mentioned in terms of payment, how do you get providers engaged and participating in these kinds of programs? Obviously, a closed system where both PCPs and specialists are employees of the organization, it's an easier challenge to be able to tackle. Some of these collaborations between community health centers and hospitals require some, pretty intensive workflow studies. How do we best exchange information? Sometimes we have two different platforms. We're exchanging information between an EHR and an eConsult solution. So it's nice to be able to share different types of practices across organizations and be able to connect those who are using similar types of workflows. I should mention that, before I move on to the next slide, we've had some excellent support from both California Healthcare Foundation and Blue Shield of California Foundation out here in California. As you all know, these pilots don't just start without any funding whatsoever. Blue Shield has generously funded a good number of public hospitals to be able to really spearhead their efforts in collaboration with their counties or their managed care plans. I mentioned earlier, it's been a great opportunity to be able to somehow standardize documentation for these eConsults, and so now having our public hospitals and clinics be able to track these, we really have a better story for our state. We can show how this type of program is being done more consistently across hospitals to be able to collaborate with their local care delivery partners. So between FQHCs and public hospitals, being able to document these occurrences or these encounters have actually taken place. And then when we get into the questions around payment and reimbursement for these types of encounters, as Darren mentioned, it would be much better if we could move from a fee-for-service process to one that's more of a value-based system. However, we are still stuck in a fee-for-service world. And so in this time of transition, it is helpful to be able to show how much time is being spent in electronic consults. And as was already mentioned, it's important for specialists to be able to document how much time is being spent in response. Sorry, I'm stuck on this slide. Oh, there we go. One of our challenges for being able to prove our case out here in California is to determine how much an eConsult is worth. And I think over time, probably over the past 5 years, managed care plans have struggled a bit with how do you document and how to time box how much time is spent on an eConsult. So what's been helpful is to be able to look at studies across the country and also in Canada. Claire Liddy is a great expert who was able to really document which types of specialties tended to take how much time, be able to really account for the time spent by the specialist in response. So you can see here that the majority of eConsults were performed in less than 20 minutes. It's something that is become much more manageable by the specialist and something that we can show does save time and increase access. So now we're looking to work with our state Medicaid to be able to really determine how to best reimburse for this, and that we do still have a large fee-for-service population out in California. And in order to be able to deliver care to this patient population, we need to be able to engage specialists who are often reluctant to take on this type of population. And I stole from Darren in this slide here, this process flow he referred to in his earlier presentation, so I'm not going to talk about it much other than to note that eConsult as part of the referral process has been proven across our state to really improve our challenge about access. And we're being called by our state Medicaid to really look at timely access and figure out how both payers and providers can tackle this challenge. It's already been proven that eConsult is doing this, taking what could be a 3-month wait for an in-person visit and reducing it to what's an average of a 7 calendar day response with partnering with a local network. Obviously, if you have a remote network, if you're working with a vendor that allows for specialists to respond either out of state or out of the local area, this often happens in far fewer than 7 days. And just on that same note, in terms of network adequacy, this is another challenge that our state frequently calls on us as a work group to address. How do we deal with our gaps in care? How do we deal with these areas that are really scarce in terms of specialists? We have some counties up in far northern California that don't have any MDs. So we're tackling the challenge of creating networks, and eConsult does prove as a means of doing this. It may be a remote network. It could be completely on the other side of the state, or it may be just allowing a PCP to connect with a provider that's 3 hours away. But eConsult has proven that it does allow us to increase and improve upon our network adequacy. So in getting close to the end here, just wanted to note that we really do take this as a shared responsibility across our eConsult stakeholders. We have our FQHCs, managed care plans, counties, and our hospitals. Each of those have different sources or pots of funding that they are using currently to support eConsult, but we still have gaps. And we're in this time of transition, especially around FQHC payment. So we're really taking this as an opportunity. We have about 3 years until payment is really going to change in California. So within that 3 years, we're really trying to tackle this and get state support to be able to bridge that gap. We're looking at a few different ways to do that. And as is mentioned here, we really do want our state Medicaid to be able to support our use and our consistent use of CPT codes, acknowledge that these are reimbursable codes. Acknowledge that any sort of audit that's taking place, the way that our plans are audited, is really acknowledging that plans and providers are using eConsult to reach some of these goals and be able to improve upon these challenges they're facing in terms of timely access and network adequacy. And really building upon existing programs by our state Medicaid, our DHCS, taking the incentives that public hospitals are getting to use eConsult and being able to potentially share these cost savings with their clinic partners. So we still have a lot of work to do. We're being asked now to really actively engage consumer organizations, those who are most vocal in terms of access, and the fact that we do have to acknowledge that the perception of eConsult, what may be an incorrect perception, is that we're trying to avoid face-to-face visits. We really do try to think about the way consumers would perceive eConsult and make sure that they understand that this is a way to give them the right care that they need at the right time, in the right place, obviously. So engaging those consumer organizations and really, as Darren mentioned, taking the managed care plans, taking the payers, and really requesting their leadership and their support of these programs. And now looking at a good number of these programs that are, gosh, 5 years and older, taking some of these programs and looking to see how they are demonstrating cost savings. It's hard, obviously, to be able to take increased access and translate it directly to cost savings, but we're working on doing that through some of the downstream effects of being able to implement eConsult. And coming up in fall, we do have a biannual meeting of our eConsult work group. We encourage any of those who are interested in joining us out in Sacramento to come out and be able to contribute to the conversation with some of your experiences. So Danielle, I think that's it. And some of the topics I covered may be those that Darren touched upon too. So if there are any questions, let us know.
Fantastic. Thank you so much, Lydia. That's a great perspective in relation to, addressing, first identifying and then addressing some of the barriers and really going at this and making eConsultation not only a viable but sustainable model moving forward, and all of the research that you've done in order to support that happening. So thank you very much. We do have one additional question in the queue, and because it's a fairly long question, I'm guessing that you and Darren may have already read through that. Do either Libby or Darren, do you want to address Florence's question?
Darren, have you had a chance to read it?
Yes, I have.
Okay.
Well, and
tell us, Ike, you want to take it?
Yeah, so the questioner is talking about rural integrated telepsychiatry and describing, the common scenario in such settings where, a patient is connected to an offsite psychiatrist, and two different ways that their guidance can be applied. One of them where the offsite psychiatrist has responsibility for actually implementing the treatment and prescribing the meds, and the other where the primary care provider takes their advice and guidance and implements it. And he's asking if either of these two scenarios constitute an eConsult, and if so, why? And I think my initial answer is no. I think one of the defining characteristics of an eConsult is there's no patient involved. I mean, there's a patient involved, but not directly. I think this is an example of, in the examples when I was talking about licensing, the establishment of a patient-clinician relationship. In this case, where a psychiatrist is talking directly to a patient, to me, that kicks it into the more commonly understood notion of what telehealth is, or of direct telehealth care, rather than an eConsult. I wouldn't call this an eConsult, either of the two scenarios.
Thanks, Darren. And one thing that you can poke holes in, but I think one thing we could probably all agree on is that part of the definition and the thing that makes eConsult special is that it's a provider to provider encounter, and that it's asynchronous. So it's not time boxed, and the patient need not be present. So that's what makes eConsult potentially, as you mentioned, an improvement in access.
Mm-hmm.
Yeah, agreed.
Great. Well, it looks like those are all the questions in the queue. Please feel free, for those who are still on with us, if you have a last minute question while I'm kind of wrapping things up, feel free to shout out those questions or put those in the queue. But I did want to share and hope that folks will be able to join us again next month for the National Telehealth Webinar Series. It's the third Thursday of every month. Our next webinar will be presented by Kim Schwartz and Becky Lundgren of the Central Oregon Telehealth Network, and they'll be sharing experiences from their chronic disease remote patient monitoring project. And so all of the details are there. And finally, lost my control there for just a second. We always like to collect your evaluation information, your feedback on these webinars. We really are doing these in order to help our stakeholders learn and utilize information to advance your program. So really hope that this is helpful for you, and would really love your feedback. It's a really short survey. You can click on the SurveyMonkey link. I believe we'll put it in the chat as well, so that you can get that link, and we'll be sharing the recorded version of this later on as well, so you can grab it there. But we'd really appreciate your feedback. And it looks like we do have a couple more questions. Will we get the slide deck? Yes, that will be available, and everyone will get an email providing details on how to get that. Another question: how do bigger centers enable their specialists to spend time on eConsults with so many other swirling priorities? Great question. Who wants to field that?
Yeah, I mean, this is Darren. I have to say I can't entirely answer that. I do know that larger centers that find this, one of the biggest reasons some of our large centers that we work with in Connecticut have signed on to do this is because they have difficulty with access issues. They may have a 3-month wait to get patients in. And so I think some centers see this as a really important activity to help, reduce that demand and to prioritize and triage, who needs to get in right away and which patients don't need to. And I think San Francisco General has shown really compelling data on how they've been able to improve access by using their version of the e-referral process. Other sites, I honestly can't say.
Yeah, Darren. So Darren knows a good number of these organizations out in California, and so from the FQ side, as you know, it's a very convoluted payment system, and how to get that PCP away from practice in order to deliver eConsults can be challenging. So what we've seen probably the most sophisticated programs do is set aside an hour of admin time for their PCP to deliver the eConsult. And on the specialist side, within a public hospital setting, back to Darren's point, it is part of their attempts to be able to increase access where there is none. In addition, we do have incentive programs under state Medicaid that support that, not a per encounter or a per hour time spent on eConsults, but that through annual reporting, they could take that incentive and potentially compensate for that time spent.
Mm-hmm. Great. So another question: there is a consumer movement for patients to have access to all their PHI. Would this include them seeing the eConsults? Thanks very much. Great answers so far.
Yes, yes, it would. The eConsults that we return back to the primary care provider come back and look very similar to a standard consult note, and they are intended to be included in the chart in the referral section, just like a face-to-face. So yes, definitely. And eConsults are not de-identified. And I don't think that they need to be, but because eConsults include lab reports and MRI results and pictures in many cases, I think the process of de-identifying them would be incredibly cumbersome and not necessary.
And Darren, would you say that probably most, the entities that you're working with, your CHC, your organization probably has business agreements with most of these organizations anyway, so that.
Well, I mean, so we have a standard sort of BAA that we
right.
Whenever we work with another organization. So yeah.
Right. Yeah. Okay. Great. So I think this is the final question. Thanks for the great presentation. Darren, where can we read your study? And Libby, I'm interested in learning more about the work group. Might have a new member.
So there's two. The first presentation, the lead author is Wanda Aliwala, who is from San Francisco General. She worked here at CHC and moved on to San Francisco. And I'm the second author, and it's in the Annals of Family Medicine in March of last year. The second study, you're going to have to wait. Unfortunately, it's been approved and accepted by the American Journal of Managed Care, but it's not slated to come out until, I think, actually 2018, unfortunately. So be happy to share sort of the findings. And so the graph that I showed you is actually a depiction of some of the results that are described. But unfortunately, the publication delay, the time between doing research and getting it in print is such that by the time it's in print, it's irrelevant.
Okay. Thank you very much. And we're happy to facilitate sharing of any information that you're comfortable doing so, Darren, if that's helpful. So Libby, it does sound like Heather Zampano is interested in joining your work group or learning more about it. So.
And Danielle, I think you shared our emails. Well, if you haven't, then that's the best way, and we'll get anyone who would like to join onto the list.
Okay, fantastic. Well, it looks like that is the rest of the questions, and we really are right up to the 3 o'clock hour. Darren and Libby, thank you so much. This has been incredible. We really appreciate your time and sharing your expertise and the outcomes from both of your perspectives. Thank you again so much. And thank you to all of our attendees for choosing to spend your time with us this afternoon. We really appreciate it, and we hope you have a wonderful Thursday and weekend. And with that, we will